Okay. So good afternoon, everyone. I am Dr. Mehak Bansal, Consultant Pediatrics, SPS Hospitals, Ludhiana, and we are Pediatric Intensivists here. So I think we all know about dengue and its management, and we have been dealing with the dengue fever and its critical phase for the last 12 years. So we are not here to, formulate a guideline or tell you how to manage dengue. We all know about it. But when I was searching through the literature for, the evidence-based guidelines, and I think all I saw was a Sri Lankan guideline, an Indian guideline, a WHO guideline. There has not been enough literature, some research on dengue. Not unfortunately, we don't have a vaccine also of dengue right now, but dengue is changing every year. Every year we see something new about dengue. Maybe it's a strain change or some parameters, they are changing every time, and the sickness and the severity also changes year by year. So this time we felt that we are getting a lot of sick dengue patients, and who are deteriorating rapidly, and there has been some changes which we found in the last 1.5 months, you can say, with dengue. Especially, the confusion when we have a child with fever, whether he has dengue or COVID. So all these questions we are trying to, sort out in this, and in this talk today. And I think now we'll start. I'll share my screen first. Right. Dr. Vikas, can you see my screen?
Yes, I can see your screen.
Okay. So welcome to the pediatric grand rounds. I think this is the second one, and this time we are dealing with dengue this time, and it's the changing paradigm in the management of dengue fever. As we all know, there are three phases of dengue fever. That is the febrile phase. As you can see in this, that this is the phase where we have fever, and by the 5th or the 7th, the fever starts subsiding. The fourth, you can say the fourth to the 7th day, this is the part where we can go into the critical phase of dengue, where we can have shock, we can have multi-organ dysfunction, and we can have bleeding. And after that, the patient goes into the resorption or the fluid overload phase. If the child has been in the hospital, he can go into a resorption and the fluid overload phase. So that's called the recovery phase or the resorption phase. Coming to the hematocrit, you can see that the hematocrit shows the same trend, that during the critical phase it starts rising, and it has shown that a rising trend. And coming to the platelets, they initially show a fall during this phase, and then they start rising again. And so coming to the dengue classification, as we all know that we have dengue with warning signs and dengue which is a severe dengue. Now, I think when we are doing a OPD, or where we are doing OPD practice or at the centers, we can identify which patient is going into the severe dengue or the plasma leakage phase just by identifying the dengue warning signs. That is the abdominal pain, the persistent vomiting, any bleeding, any restlessness and lethargy, liver enlargement. So this is the WHO talking about the warning signs, where if we pick them in time, we can save our children from getting into the plasma leakage, severe hemorrhage, and organ failure phase. So that is important. And coming to the diagnosis of dengue fever, we all know that it is NS1 and IgM. So NS1, in the primary infection, the NS1, starts increasing at the first to the third day, and gradually goes down. But in case of the secondary infection, you can see that the IgG rises a bit earlier as compared to the in case of the primary infection. And we have the other things, that IgM and NS1. So first 3-4 days NS1 does have importance, and later on IgM. So I'm going to start with a case. As I said, today it will be case-based management. And my first case is a child who's Adil, a 6 months old male child who has come with fever for the last 2 days in your OPD. And the mother is complaining that whatever she does, the fever is not subsiding, even giving with crocin and tappet sponging. So, my questions to Dr. Vikas are the following. First, Dr. Vikas, is this dengue or corona or any other illness? How will you identify and how will you tell the mother what to do?
So it's in this pandemic, it's very valid question because till now, because of wearing masks, we are not seeing any other flu cases. So whatever fever we are seeing, it's basically either it's dengue or corona. And so how we have to differentiate it? So what I do is in my OPD, I always ask that if any other family member is having fever, or if the answer is yes, that any other family member is having fever, then I ask them whether he's having dengue or his platelet count is stable or it's falling down. Normally, people identify dengue with the cell cutting. So if I tell them that if the fever is there and if the other person is also having any problem with the platelets, that means the same mosquito is biting the all other family members. So that means this child also might also be having dengue. But if the parents reply that yes, others are also having fever, but they are having cough cold and it's not a very high grade fever for adults, or it's a low grade fever, or they are having any throat pain, cough, colds, sense of taste and smell is not there, so then definitely we should consider that the child is also having this COVID-19. So this is how, this is not a foolproof idea to identify, but definitely you can make it out. Another common thing is dengue fever from the start one. Most of the children, they present with high grade fever. While for COVID-19 in children, we see for small children, the illness is generally mild and the children come with the low grade fever, which subsides within 2-3 days. While for dengue fever, the fever, as we all know, that fever lasts high grade for 3-4 days, then it starts settling down within 5 to 7 days, it will settle down. So the clinical criteria is the family members having fever or COVID-like symptoms. Second is the type of fever, how it is there. Like if the family members are having, if the child is having very high grade fever from day one, then generally it's then possibility of dengue is more common rather than COVID. And third thing is also because the children are not going out, they are in the house, so they are not directly exposed to COVID. So they will be bystanders if they are getting any COVID infection. While dengue is a mosquito which is actually a home-based mosquito which commonly resides in the indoors, and it basically bites more commonly children, as the children are always indoors. So that's how clinically we can make it out whether it's dengue or COVID.
Thank you, Dr. Vikas. Have you seen any cases which have dengue and COVID together as well?
Yes, now this is a very valid question. Dengue with the COVID is a common thing. In this season, we have almost, I think, seen 7-8 cases where the child actually, we have admitted the child in ICU with the features of dengue, typical 4-5 days high grade fever, falling platelet count. Otherwise, child has mild, like we said, dengue with warning signs like vomiting, a pain abdomen, but no shock or hematocrit was not rising. The child was there because of poor oral intake. And as we have a policy that we routinely investigate every case who is getting admitted to the hospital for COVID-19. So we come across 7 to 8 cases where these were having coexistent COVID also. Second, we had some cases who were looking like dengue, but ultimately they turned out to be COVID positive rather than dengue was negative. So this was another variety where actually they came with fever, leukopenia, and thrombocytopenia was not marked. And they were having more other symptoms like body ache, headache, and exhaustion. These were the symptoms as we are commonly seeing in adults. But these were the cases who were slightly older children. Like these were the children who were, I'll say, beyond 10 years or beyond. So those children who were coming, who were smaller age group, like less than 10 years of age, these were more commonly having dengue predominant symptoms rather than the COVID predominant symptoms. And if they were coming, they were diagnosed with COVID, then the symptoms were very mild, and second, third day they became asymptomatic and were sent home. And third variety we are seeing is like the patients who were who had dengue, and who had COVID, and now they came with the active dengue infection. So they are actually coming in post-COVID syndrome, what we call it as, and this post-COVID syndrome is mainly precipitated by active dengue infection. So these three type of children we are seeing nowadays in our ICU.
Anything, Dr. Vikas, which you see, how can you differentiate between PIMS TS and dengue fever? I think this was a very valid question and raised by many that, how will you differentiate between dengue shock and a PIMS TS like picture?
See, dengue, like how we will differentiate is if the child of a dengue comes to us with the active high-grade fever, and you can see the other post-inflammatory markers like are coming very highly positive. Like you can see here, dengue generally we see leukopenia, but PIMS TS we are seeing they come with a high TLC. First, second is the CRP counts. CRP is not very high in dengue fever patients, while in PIMS TS, the CRP, if you follow CRP, they come with very high CRP. And third thing is they will have a like polycerositis, again like dengue, they can have ascites, they can have pleural effusion, they can have, but other common thing was like conjunctival congestion, involvement of the mucous membranes like mucositis, which these are the cases which are not we commonly see in dengue, but here in PIMS TS we have seen these cases that the children coming with like red tongue, mucositis, conjunctivitis. These were also predominant features. And generally, like here, the fever is more than 5 days. It's not like in dengue, which commonly see fever lasting for 5 to 7 days, and then the defervescence is seen or the patient becoming sick. These patients, the fever was history of fever was more, and other organ involvement, particularly, it was not very severe. Like it's not like the patient generally they came with not in a very sick condition. And when we saw that they are not exactly fitting in dengue, and we investigated them for other inflammatory markers, like I told you, CRP and ferritin levels, we found CRP much more higher as compared to ferritin, and TLC on the higher side, and involvement of the mucous membranes. These were the features which actually alerted us to investigate them for this post-COVID syndrome or PIMS TS.
Thank you. I think we have a patient as well. We've seen a few patients who presented more like Kawasaki disease-like illness with high counts, high CRP. Although ferritin was also high, but I think one of the parents in the family had COVID or child was previously COVID. So we have certain clues to the diagnosis, how to differentiate between PIMS TS and the dengue hemorrhagic fever or dengue shock. Right. Coming to the next question, what difference are you seeing in the dengue cases these days? I mean, last year also we had dengue, last to last also year also we had dengue. What anything different are you seeing in your OPD where in the dengue cases or in the IPD management?
See, we are seeing OPD, I think cases are presenting the same. Only issue is what we are seeing is that this time OPD cases, the deterioration is quite rapid. Within 24 hours, the child who was seemingly well initially, who had visited your OPD one day prior, and the next day he straightway comes to emergency in shock. This is one different thing what I have seen in these days. Second thing what I'll say is for IP cases, with what we are seeing cases quite severe this time, and cases are behaving differently. Like initially we used to see cold clammy skin, very thready pulse or weak peripheral pulses, and the patient they used to respond to fluid, and the inotropes has a very less role. But this time it is different. As the talk progresses further, we will tell you in quite detail that how we saw these cases which were different on IP basis, and how they were sicker, and initially how we were not able to manage them as effectively. That after discussing and reviewing the literature, we are able to do them now. But for OPD basis, what I'll say is that what we are seeing rapid deterioration this time. After seeing these, I can tell you that in this season, I have seen 4 or 5 patients who have come to the OPD with many reports. First CBC for normal, almost normal. There is no hemoconsumption, platelets were to the tune of around 1.7, 1.8 lakhs. Second CBC again more or less similar. Platelet, this hemoglobin is marginally up, like 11.5 to 12, and platelets are again 1.25 lakhs. And third, because the parents are now more and more due to dengue, they keep on repeating the CBC on their own, even if you're not suggesting them. And third report, once they, after initial two reports, they are quite fine that yes, platelets are not falling much, or already there is third, fourth day of illness, probably nothing will happen. And suddenly on fifth day, the child becomes very sick, and on that day particular, when you want to CBC done, they will tell you, doctor, and it was normal. So now what's the need of doing it? And once you repeat it, and you will find there's a haywire and there's a lot of hemoconcentration happening, and platelets are somewhere around 25-30,000, which is actually frightening for the parents also and for you also. So I see is that a lot of rapid iteration happening this time.
Okay, yeah. So what will you, I think in my OPDs mostly patients come and they say, डॉक्टर साहब फीवर नहीं उतर रहा, बहुत क्रोसिन भी दे दी, टैबलेट स्पंजिंग भी कर दी, बहुत बुरा हाल हो गया है, तीसरा दिन हो गया, अब चौथा दिन हो गया, फीवर नहीं उतर रहा है. What do you think? Like, how will you counsel this patient, and what will you prescribe if the fever doesn't subside with crocin?
See, if I see a child for age, for weight according to the age which is normal, then I am not very much worried that this child will come to me with the severe mucositis and a lot of hemoconcentration and shock. Generally, these are the kids who generally tolerate dengue fever well. So I tell them to, because I know the fever for first 3 days will be very high, so I tell them to first use crocin or paracetamol. And if the fever doesn't subside with crocin paracetamol, they can use ibuprofen combination with paracetamol, or they can use mefenamic acid. Now the question comes when we differentiate that yes, you can use mefenamic acid, but you cannot use ibugesic or ibuprofen. This doesn't hold true. If there is no literature supporting it that the mefenamic acid is safer to use rather than ibuprofen. Both of them are NSAIDs. Both of them have similar action. So it's just the salt is different, but their action is same. So you can use either mefenamic acid or either ibuprofen or their combination, whatsoever is easily available to you. Both are safe, but yes, we should tell them that if already the active leaky phase has started, at that particular point of time, they should not use NSAIDs, only use paracetamol. Like between the third to fifth day, because the fever is generally high for first 2 to 3 days. After third day, the fever should start coming down if it's a normal dengue. But if this dengue is going to get complicated, this fever will not settle down for 5-6 days also. During this phase, between 3rd to 5 days, you should tell them to only use paracetamol, because here, if you are using NSAIDs, it will actually lead to hyperinflammatory syndrome. Even this has also very less evidence, not class 1 evidence is there to support that the NSAIDs are actually promoting it. So for first 2-3 days, they can use mefenamic acid or ibuprofen, or even adults, they are using nimesulide also for fever if it is not subsiding.
Right. Yeah, I think that was a major concern. Many patients come, and I think we can prescribe them an SOS dose as and when required in the first 2 days. Yeah. And the next question is, when would you like to investigate this child? Normally, I mean, in the last year, we used to investigate the children about 5th, 6th day, or we used to tell them that, okay, after 5th day, the fever will go away. But if you can come, if you have any danger signs, we'll get it investigated. But what is your practice right now? Do you routinely investigate this child, or do you wait for the danger signs to appear?
See, now investigation wise, most of the time, as per my practice, the children parents, they come to me on OPDs on first or second day of illness. They will come with the high grade fever, and they want, like, they will tell you, doctor, write some tests so that I want to know whether my child is having dengue or not. Now this is a bit tricky. So for first 2-3 days tests, basically you will get only things which can tell you whether this is a viral hemorrhagic fever. Like you can get NS1 antigen tested. So NS1 antigen will be positive for first 48 hours or maximum 72 hours. Beyond 72 hours, NS1 disappears, and then antibody will appear after 5 to 7 days. So first thing is, if we want to test this child for between first 3 days, then definitely we should write about dengue NS1 antigen. Because NS1 antigen is positive, then we are sure that we are dealing with some sort of dengue-like illness or dengue fever. And between first 3 days, the CBC is not going to tell you much, but yes, it can give you a baseline value for your hemoglobin and your hematocrit, so that a subsequent CBC you can correlate whether this patient is having any hemoconcentration or not. Because nowadays we see that even the affluent families, the kids are anemic because they are on milk dominant diet. So if you are getting this child investigated on the fourth, fifth day, so you will not be able to know what is the baseline hemoglobin. So you will not be very sure that whether this child is having any hemoconcentration or not. So for first 3 days, if we should get a CBC done and a dengue NS1 antigen done, which can tell us that what we are dealing with in this child here. I will say that because of this pandemic, we are not seeing any other illnesses. Typhoid is almost gone. Flu, just last few days, I've seen 2-3 cases where the child is having cough, cold, fever, and all the families having cough, cold, fever. Even it's very difficult to differentiate whether they are having COVID or simple seasonal flu. Or we are seeing children only with allergic kind of cough because of this crop burning, crop residue burning that we are now seeing. This is last 2 days, some patients with the reactive reactive lung disease, or with the allergic rhinitis type of features. Otherwise, prior to that, there was nothing like that happening. So first we need to do a CBC and NS1 antigen to have a baseline thing that has to be ordered in first 3 days. If when most of the time you're seeing this child, and then you should write down that on 5th day we want this test to be done. On 5th day we need to have a CBC again, and if you strongly suspect, then or the child is coming to the first time, then 5th day you should order for maybe IgM and IgG antibodies. This, if you are having these two reports, then it will be helpful for you to make a mind that whether this child is getting any complication or not. If the patient has done already 2 investigations, like on first day of fever they have one CBC, on third day again they have to second CBC, and both the reports are more or less similar, and they have made up their mind that probably the child is not having any severe kind of disease, then also you should insist that third CBC should be done on 5th day, because this will actually give you that whether the child is getting some complication or it's just simply fall of platelets, or nothing is happening.
I think it's very important that we do the investigations early this time, especially when you have to differentiate with COVID or any other illness. Once you have a NS1 positive or a CBC with leukopenia in your hand, you know what you're dealing with, because otherwise parents are also confused that when I'm dealing with COVID or dengue in my child. Right. When would you like to call this child for follow up?
So again, like if the child has come, I really want to see the child on 4th or 5th day. That is very, very important. If the child has come to me on 3rd day and he's hale and hearty, oral intake is fine, only high grade fever, nothing else, then I try to explain them that now already 3 days of initial illness are over. This child has been normal till now, but for another 2 days, what are the things what we have to observe? One, the fever goes down, child starts having some rash, oral appetite improves. Okay, it's fine. The child is going normal. This is not a complicated dengue. We all know rash is a sign of recovery. But if the child on 4th, 5th day starts having pain abdomen, child becomes lethargic, oral intake going down, vomitings, diarrhea, then this is the child which you want to look again and again. Probably daily, if you find the child is well in the OPD and well on investigations, and oral intake is moderate and no hemoconcentration happening on CBC. But if the child doesn't seem to be well, and then we should insist the family that they should admit the child, because this is the child. If during this 24 hours, if he doesn't get proper amount of fluid, and child goes in hemoconcentration, then definitely he can go land up in shock and multi-organ dysfunction. So 4th, 5th day follow-up is very, very important.
Right. And I think you said rightly, and I think you look for these danger signs when you monitor this child that he's going into the critical phase of illness. What signs do you feel other than this, which are very, very important, we should tell the parents to look for in case of that the child might be going into the critical phase of illness?
Like already we have discussed it. Infection of dengue are actually leading to more of hyperinflammatory syndrome. And then we should be able to see who are the other potential candidates who can have complications, like a obese child. Any child, even a obese child of 1 year of age, even a obese child of 3 years of age, obese child of 5 years of age, or a obese child of 10 years of age. Any child who is more than 95th percentile of his age criteria, he is going to land up in, is the probable candidate to land up in complication. So any of these child, if you are coming to with initial fever and you diagnose that this is a dengue, then you should alert the family that he is the one who is having major comorbidity, which is actually troubling in dengue. So this has to be monitored properly. Again, you tell them that this much amount of the fluid which the child has to take in 24 hours, and tell them that if the child keep on pressing the child's liver, we tell them that the right hypochondrium need to be checked. If child cries or says that there is a pain on right hypochondrium, this is the time that you need to see the child again. This already that this danger sign has come, and this has to be shown to a doctor. And third thing is, important thing is urine output. Smaller child, you see how many diapers the mother is changing in a day. A bigger child, you can monitor it. You can tell them that they can fill a liter of bottle. They can keep the urine and see that how much the urine the child is passing. Almost if his child is able to take around whatever the intake is, if the child is able to pass half of that much in urine, that means he's not going into any complication. If he's not passing urine well, you need to see the child again.
Right. Okay. So yes, as you said that you've counseled well the parents in terms of fluid intake and danger signs. So to summarize, we can say that you can counsel the parents that if on the 4th to 7th day of illness, if the fever of the child settles, he develops rash and he develops itching, and your oral intake and activity of the child improves, it indicates that the child is recovering. However, if child develops any of these danger signs, you have to write it down on the prescription and explain them properly, like you write paracetamol and like you write uh, Unilandro, whatever. You have to write on the prescription these danger signs, which can occur right from 3rd day to the 8th day. That is severe abdominal pain, persistent vomiting, हाथ पांव ठंडे होना, cold extremities, poor oral intake, lethargy, irritability, restlessness, any abnormal bleeding, red spots over the skin, or difficulty in breathing. We had one patient who was brought dead because the child was having abdominal pain and irritability for the last 2 days, and parents were skeptical to come to the hospital just because they were afraid of COVID. So we lost that child, but I think these danger signs should be explained so that they report to immediately to the hospital or to you if they develop any of these symptoms. From a fluid perspective, I usually give them a picture, or WhatsApp them a picture, or write them on the prescription. They need to drink these fluids to keep the hydration of the child, to concentrate less on milk and more of electrolyte containing substances, ORS, nimbu pani, coconut water, etc. So this fluid intake, the quantity and the urine output, these all are very important from OPD perspective, other than the prescriptions you give. So in this case, Adil, the first day CBC was done, showed a HP of 11.5, TLC was 5500, and the platelets were 1.75 lakhs. The dengue was positive. So I was happy that I'm dealing with dengue in this case because father also had some illness a few days back. The next day, the patient went themselves because they were worried now what is happening to the platelets, and they got the CBC done. The HP was a little up and the platelets were fine, so they were okay. I called them for follow-up on the 4th day. They came about bit ignorant about the condition of the child. When I saw that child, I was found to have cold extremities, poor oral intake, and you can say oral intake was borderline, and the parents were just ignorant about the condition of the child. I asked them to get a CBC done, and they were surprised because they had done a CBC the day before. But when I did the CBC, I found that the PCV was 45 and the platelets had dropped to 30,000. I admitted this child. On admission, the BP was normal. Just resuscitated. Just gave this child hydration. Platelets monitoring were done. Fever for fever, IV paracetamol, rapid sponging was done, and later child improved and was discharged. So this child was well picked up in time. monitored in the hospital and discharged in a stable condition. So to summarize, yes, counsel the parents that the high fever won't go for another 5 to 7 days. Early investigation, definitely call the child for follow up every alternate day or every other 2 days, and especially on the fourth to sixth day of illness, to examine the danger signs, the hydration, the sensorium, and get a CBC done definitely on the fourth to sixth, especially on the fourth to fifth day, to find out what is happening to the child. Please explain the danger signs and explain about the importance of fluid intake and chart should be provided. Counsel the parents the steps that can be taken at home to prevent dengue fever to the other kids. I think one has suffered, the other should not suffer at this point of time. This is the just the outpatient management given by the CDC, and I have covered all the points which are given in this management in a CDC guideline. So coming to the case 2, so this child, his name was Garv, and he was brought to us with complaints of fever to 2 days, abdominal pain, and poor oral intake since few hours. So this child came around afternoon, around early morning, and the parents said that since last night he's not eaten anything. On admission, this was his third day of illness, and the child was found pulseless, having cold, clammy extremities. Although the BP was NIBP was 130 by 90, heart rate was 150, respiratory mildly tachypneic 30 per minute, and he was afebrile. Weight was 65 kgs, and he was a bit CNS drowsy, and the abdomen was very tender. So investigations, I think we all do the investigations, but I think I want to emphasize this case the serum ferritin. I would come later about the importance of serum ferritin, but I think this is one investigation should be done on IPD basis. It gives you a lot of information about the severity of illness. Unfortunately, we don't have many studies, but we have found that it definitely correlates to the severity of the illness of the child. We do a and we do a renal function. Shweta ma'am, can you mute yourself?
नंबर डलाया है लगता नहीं सर्जरी के पहले नंबर तेनु पहले मेरे नंबर नहीं पहले तो सर्जरी हां पूरी ऊपरी की मेरे सर्जरी ऊपरी हां जितना साइड को लाया
Sorry. Okay. So we do a CBC. Along with that, we do a renal function test. We do a SGOT-PT. We definitely do a INR to look at the liver status. We do a blood gas on admission. That can be a VPG as well, and a dengue or NS1 antigen or dengue serology depending upon the day of the illness, and definitely a serum ferritin level. So in this patient, we had a hemoglobin of 15.6. The PCV was 46, the TLC was 5600, and the platelets were 20,000. Although the renal parameters were quite okay, there was mild transaminases and the INR was normal 1.4. The lactate blood gas was just 1.6 and it showed not much acidosis. And the dengue NS1 came out to be positive. And since we all do SARS-CoV-2 PCR in every case, we get admitted to the hospital. So that was also negative. So this is the algorithm given by the WHO for the management of compensated, and the other one is for the hypotensive shock. I think we all know this algorithm by heart, and I know I'm not going to discuss this because we all know this. But according to this algorithm, we also used to work, and we started giving this child a fluid bolus, which I gave 20 ml for 1 hour, and started him on fluids 10 ml per kg per hour. And because the shock persisted, I gave him adrenaline infusion. Arterial line was placed and resuscitation. The second fluid bolus was given 5% albumin, and adrenaline was continued. The ferritin was very high. This was, I think, 11,000 in this case. So he was started on IV dexamethasone. So after 6 hours of resuscitation, when we did the fluids according to this protocol, we saw that the child became very edematous. He developed ascites, pleural effusion. The renal function deteriorated. He had developed a huge compartment syndrome in the abdomen. the urine output dropped, the lactates worsened, and the child had to be started on renal replacement therapy in lieu of AKI. And even his liver function deteriorated with an INR of about 5. So we had to use PRRT in lieu of AKI and both ammonia scavenging agents. So the society fluid and pleural fluid was tapped, and the child kept on developing recurrent hypotension. We gave lots of things: colloids, crystalloids, blood transfusion, range, INR. But ultimately, the child expired with massive pulmonary hemorrhage. Right. So on retrospective analysis, thought that I think we gave too much of fluids in this case, and we were chasing the hematocrit and peripheral pulses, which led to fluid overload and lots of third spacing. We used less colloids initially. The choice of adrenaline as a first inotrope did not work in this patient. We were having tachycardia, we were having cold extremities, and later on, when we put an arterial line, we found wide pulse pressure instead of narrow pulse pressure, despite having deep peripheral pulses and cold extremities. So norepinephrine was started later when the refractory vasoplegia was set in. I think new clinical and biochemical markers findings in these sick severe dengue patients are very high ferritin levels. We are seeing very, very high ferritin levels and rapid progression from hepatitis to a fulminant hepatic failure. So I think we went through lots of review of literature. I think we talked to a lot of people all over the country, and they took input from many people. And I think we to try to change our protocol in a way that I think we would give less fluids and concentrate on other things. Uh, Let me describe my case first. The next case we managed after this. We've actually, after changing few things, we've managed a lot of cases, but I've put in one case just to see that even few changes in my management have made a humongous difference in my illness and my mortality and the output of the patient. So coming to this case, this was an 11-year-old
And I just want to add one point.
sick as compared to the previous child. He was
I want to add one point.
fever for 4 days. Oral. Please, everybody, mute yourself.
Mehak, I want to add one point here.
Yeah.
In the second case, I just want to pick up few things what I want to tell from my side. One is like, when a sick patient comes to us and we are managing a sick patient, sometimes clinical parameters are deceiving. Like in that child, our NIBP was showing a normal blood pressure, but pulses are not there. And as we know that dengue generally is a disease where we all know that the fluid leaks out from the capillaries leading to high hematocrit values. But here what we are seeing nowadays that once you see the patient clinically behaved comes like cold peripheries, weak peripheral pulses, and an NIBP showing either low BP, normal BP or high BP. And as a traditional thing, we start them on high fluid rate and we start them on epinephrine if the patient doesn't respond to high fluid rate for first half an hour to 1 hour. But this was not here. This is not happening this time. What we did, like in these patients, after 1 hour or so, after initial fluid station, whenever we used to get bit of good pulses, we used to insert a peripheral arterial line, and we found that it's a very wide pulse pressure. Like your systolic BP is almost 90 or 100, while diastolic BP is around 30 or 40. This type of blood pressure we see in a septic shock rather than we used to see in dengue fever. So initially, when since last 2-3 years, this type of cold, clammy, peripheral pulses poor. So we used to give pump in fluid, initial first bolus and then high fluid rate. And then if the patient is marginally responding not very well to fluid, we used to start epinephrine. But this time this was not working. Even after following the WHO protocol for giving fluid, starting with 10 ml, 7 ml, 5 ml, 4 ml, 3 ml. But we found that the patient used to get full within first 2-3 hours. Like this patient, what Mehak has discussed. This patient became fluid overloaded within first 4-5 hours. Even we have not pumped very high amount of fluid, But this patient started showing that patient had severe ascites and started showing signs of pulmonary edema or pleural effusion. So when the arterial line was inserted with a lot of difficulty, we found that probably this patient is having wide pulse pressure. So then we relented that probably the first choice was not epinephrine, but it should be a norepinephrine. By the time we started norepinephrine, now after 3-4 hours into the illness, we were late and the patient was in refractory vasoplegia and we were not able to bring the BP up. And after 6 hours, 8 hours, 12 hours of total bedside management of that patient, we lost this child. So this happened with another child also, but we used to save that child with very great difficulty after starting. That child went in multi-organ failure, was started on CRRT, and ultimately after 5 to 7 days of management, we were able to take him out from this initial shock and volume overload. So then we reviewed the literature, and as the man told you that we thought what we are seeing here is that nowadays we are getting more and more severe dengues, because last year when we used to do ferritin, hardly 10% of these patients were having ferritin value higher than 1000. But this time almost every other patient is having high ferritin values. So normal 1500, 2000 ferritin values are coming positive in our OPD patients also. So probably because of having recurrent dengue infections since last many seasons, so probably these children, this is not the first infection our children are having. They are having either third or fourth episode of dengue initially, which were asymptomatic or mildly symptomatic, and now they are getting severely symptomatic. Secondly, people are coming late who are becoming sick because of the fear of COVID. So these are the 2-3 things probably that why we are seeing more severe dengue this time.
Okay, I think that was these are the inputs we discussed, and we thought that we would change. Although we were following the same protocol as WHO, and we were using the same things which we were using in the last couple of years, but something was really going wrong, and we thought of changing our practice a little bit. So let me discuss the next case, and I would that we can discuss later on that I would ask input from Dr. Vikas that what you felt that what we did different and what made things better. So this was a 11-year-old male child brought with complaints of fever for the past 4 days, poor intake and vomiting and abdominal pain for 1 day. So he was admitted outside and given IV fluids and supportive care. He was just referred to us in view of thrombocytopenia. That unit didn't have STP. So on admission, when I saw this child, his heart rate was 140. He was tachypnic. His NIBP was 150 by 100 millimeters of mercury, and he was afebrile. He was obese teenager with weight of 88 kilos, and he had cold peripheries, clammy peripheries, weak pulses, or I could say no pulses, and had some features of fluid overload. I mean, he looked a bit overloaded as compared to normal child, and he was drowsy on admission. So when I investigated this child, I saw that he had multi-organ involvement. His PCV was 50, along with thrombocytopenia, 16,000 platelet counts, and the TLC was on the higher side. He had renal dysfunction. His creatinine was 1.2 with a potassium of 5.3, a transaminases with an INR of 2, suggesting multi-organ involvement, and the ferritin was very high, 12,000. And when I did the blood gas, the initial lactate was 4.5.4. So I inserted arterial line in the first hour of the management of this patient, and that lactate was 5.4. He came out to be dengue IgM positive, and his SARS-CoV-2 PCR was negative. So in emergency, we started this child on a fluid bolus, that is the normal saline, 10 ml per kilo, according to his ideal body weight, not pumping in fluid according to his weight, which was 88 kilos. So I just gave him 500 ml over 1 hour and started him on oxygen by non-rebreathing mask. The next thing I did was, just when we were giving this fluid, I inserted an arterial line emergency, and I found his opening BP was 80 by 35 millimeters of mercury. You can see that this NIBP, this is not one, I'm just telling you this case, but I think we have managed many cases after that, and we have found that there's a wide pulse pressure. So NIBP is quite deceiving, And despite this, NIBP was showing 150 by 100 millimeters of mercury. His opening BP was 80 by 35 millimeters of mercury. I did an echo and showed the contractility was normal, IVC was collapsible, and I straight away started this patient on norepinephrine of 0.1 microgram per kilo per minute. He still remained hypotensive after this fluid, and after that I gave him a second fluid bolus of 5% albumin, which is a 100 ml bottle. So I gave him 2 bottles as a second fluid bolus. And after that, because he was bleeding from all the poked sites, I gave him RDP. This is a platelet transfusion that also acted as colloids. I didn't give any crystalloids during this time when I was giving him colloids. So just concentrated on the colloids for the next 1 or 2 hours. And after 4 hours of resuscitation with all this, I found his BP had marginally improved. It was 90 by 50 millimeters of mercury on a norepinephrine of 0.2 microgram per kilo per minute, still white pulse pressure, and a 5 ml per kilo per hour of fluid. But I did a PCV at 4 hours, which showed some improvement. So it had dropped to 45, and the platelets after the RDPs were 22,000. So that gave me some relief that yes, I mean, I have been able to achieve something in this patient. Thereafter, because he was still BP, as you can see, was still borderline, I started him on about 3 ml per kilo per hour of fluid. I stopped chasing his pulses. I was just going by the non-invasive BP and invasive BP, and I started him on 20% albumin infusion. It's a 100 ml bottle, so I started him for 20 ml per hour for 5 hours along with the crystalloid. So the crystalloid was about, if I was giving him about 150 ml per hour of fluid, and the 130 ml was crystalloid and 20 ml per hour was albumin. And after 8 hours, I did, and after 4 hours of this, you can say, I did a PCV again, and it had dropped to 43. The platelets were stable. The BP had stabilized, and extremities, which I was not chasing, had become better, and they were less cold clammy. They were a little bit warm, and I knew that the things are going in the right direction. So gradually in this patient, I tapered the norepinephrine. The fluids were tapered very fast after I stabilized his BP, and I tapered the fluids in the next couple of next 12 hours rapidly by chasing by repeated PCV and platelet monitoring, allowing him orally, and the fluids were off in the next 12 hours after the active stabilization. So on the third day, so then when the third day, I did a USG chest. The patient was stable, had good BP, warm, but had lots of B lines on the USG chest and had oxygen requirements. So I gave him diuretics, and his oxygen requirement reduced, his tachypnea settled, and the patient was discharged. Now, Dr. Vikas, what do you think it was changed in my management of this patient, and what do you feel made me do that or made us do all these things?
See, what we can make out from this year dengue epidemic, and from last year dengue epidemic is we are seeing cases of more severe dengue this time. And as we have said that how we have changed our strategies, like now if we are for first hour rapid resuscitation, like we are using 10 ml per kg fluid over 1 hour, and if the patient doesn't respond to that fluid, then what we do is we start them on early norepinephrine. And then again, third thing we do is we tolerate lower normal BP. We don't want to have achieve the average BP of that patient. We tolerate the lower values, like even like this is a 10-year-old child, and if you see the mean BP value is somewhere around 55, which actually we need a 60 mean for this age. So we tolerate lower mean value, but along with that, we see that whether the tachycardia has come down, the urine output has come up or not. This is very important. So we chase urine output every hourly. If the urine output has gone away more than 1 ml per kg per hour, we cut down the fluid. But if the urine output is less than 0.5 ml per kg per hour, then we give another fluid challenge. Now, fluid challenge means that we put fluid orders for 1 to 2 hours, not more than that. If the patient is receiving fluid more than normal of his maintenance, then the fluid has to be checked every hourly or every 2 hourly. This is how we can cut down the fluid overload in these patients. Now, secondly, if this patient has not improved with first rapid resuscitation of first 1 hour, and after starting norepinephrine, still the patient is hypotensive, then second bolus I use of albumin, colloid. Now, because we have seen if this patient gives you 3 or 4 hours only, if you have continued your fluid resuscitation, high fluid rates for first 4 hours, rather than decreasing it or rather than recognizing the need of colloids, then we are late. Then you go into refractory vasoplasia where the patient doesn't respond. The second fluid bolus colloid has made a much difference in our management since last few days. Once we have reviewed these guidelines, once we have reviewed our policy, we now use 5% bolus initially when the patient is hypotensive, or once we have maintained the blood pressure and we still see the child is leaky or the BP is rapidly going down after another 1 hour or 2 hours, then we try to put them on colloid infusion. Generally, we use 20% albumin for that phase. And we have seen that the colloid infusion actually reduces our fluid requirement for that patient, ultimately leading to accumulation of the fluid in the lungs or in the abdomen. So third thing is that now we are using a lot of steroids in dengue patients, because we are seeing almost every other patient is having high ferritin levels. So any patient who has come to us in shock with poor peripheral pulses with need of fluid resuscitation, we start them on dexamethasone or methylprednisolone. Dexamethasone we use maximum dose 8 mg BD, and methylprednisolone we use maximum dose 80 mg BD. Or if you want to go for per kg values, then it is 0.2 mg per kg per dose every 6 to 8 hourly for dexamethasone. Or for methylprednisolone, we use again around 2 mg per kg. Maximum dose is 80 mg BD for methylprednisolone. So then we repeat platelets, or we repeat this PCV and hemoglobin every 4 hourly. If the PCV values are correlating with the severity of the illness, then we actually do aggressive fluid resuscitation with colloids and crystalloids. If your PCV values are rising, but clinically the patient is not deteriorating, your BP is not falling, your urine output is good, then we don't chase only PCV. Actually, we look at 3 values: your blood pressure, your urine output, and your PCV values. If the PCV, if only one of them is haywire, then actually we look at other 2 things and we try to adjust rather than giving fluid. So don't chase one value. Urine output is very, very important, because it is actually telling you what is the perfusion of the kidneys. If the urine output is more than 0.5 ml to 1 ml per kg per hour, it's accepted. If the urine output is more than 1 ml per kg per hour, try to reduce your fluid which you are giving to the patient. Third thing is, as we have been telling you repeatedly, peripheral pulses should not be chased. Peripheral pulses can be weak during the active deterioration phase. They can be weak during the stabilizing phase or during the reabsorptive phase. You just keep on monitoring what is your heart rate, what is your blood pressure, what is your urine output, and what is your PCDs. So these are the things which we should look in total rather than only one thing. And this has actually made a difference in our life. And talking about steroids again, I tell you that we start steroids. We see 2-3 in early stabilization, early release of inotropes, very less amount of this platelet transfusion requiring after starting steroids. But yes, once the patient is stabilized initially within 24 hours, and we found that there is no much of platelet requirement, no much of fluid requirement is persisting, then we try to taper them off within another 24 to 48 hours. So very come in quickly, and even taper the steroids and stop them very quickly if you found the patient is stable and doesn't need much of high intensive care.
Right. So I would just summarize what Dr. Vikas said and what changes, what things we have been doing now. So we give a slow fluid bolus of a crystalloid according to the ideal body weight, but because we get mostly obese teenager children, as sick patients. So crystalloid 10 ml per kg over 1 hour. There has been a guideline as well by Dr. Suchitra Ranjit where she emphasized that in dengue, fluid bolus should not be rapid. It should be over 20 to 40 minutes, or you can say a 1 hour. So use the second fluid bolus as colloid. So if you have to give another bolus after this, you use a colloid rather than a crystalloid. And if a patient is coming from outside hospital who has already received the fluid bolus there, you can straight away give a colloid in your hospital. Repeat, rapidly change your PCV platelets every 4 hours. Just see what is the trend, see the trend of the hematocrit. And as Dr. Vikas said, the other things you need to look along with the hematocrit is your blood pressure and your urine output. I think stop chasing only the peripheral pulses or just the PCV.
नहीं अगला सेशन जब होएगा आज वाली क्लास अगले वाले
Okay. The other thing is looks can be deceiving. Place an arterial line. I think that's what we have started doing. At the first hour of the resuscitation, I place an arterial line and do a functional echo and use norepinephrine if I'm dealing with a vasodilatory shock. What I have seen in the last few cases, what I have managed, and a few, in the last month, I've seen that there is a decreased requirement of fluid resuscitation as well with norepinephrine. Adrenaline, of course, can be started later on in case of refractory shock. But as there has been a paper as well where they have seen that every cold patient is not having cold shock. So here also, I think there is a change where we see patients cold and clammy, but when we put an arterial line, the patients are actually in a vasodilatory phase requiring norepinephrine. So we do ferritin in each patient we admit, and if the ferritin is very high, along with the sickness of the patient, we give steroids, dexamethasone or methylprednisolone. If you are dealing with, so a little bit more, if you are dealing with, in this is a tertiary management, we are dealing with transaminases or deranged liver enzymes. Please start N-acetylcysteine infusion in case of deranged liver enzymes and correct the coagulopathy if the patient is bleeding. A slow infusion of colloid can be started along with the crystalloid if the patient is in leaky phase. So after you stabilize a BPO, you're still requiring some fluid. So please start colloid along with the crystalloid. It reduces your fluid amount of fluid as well, and the patient leaks less with colloids. You might need to drain the ascitic fluid and the pleural fluid. So in very sick patients with us where we have ascites as well as pleural fluid, in that case, just put a drain, but drain that fluid very slowly. So we put a drain, central line we have, and along with that we have 3 ways, and we just drain the fluid at the rate of 2 to 4 ml per kg per hour to avoid rapid fluid shifts and hypotension, and replace this with colloid. This we used to do it in England as well. So whenever we had high ascites, we used to drain the fluid very slowly to prevent rapid fluid shifts. Again, CRRT, which is the slow continuous dialysis, is the preferred mode. So we have started CRRT in 3-4 hour patients, and few have come out with CRRT. With PD, we have seen in case of AKI, the patient is already having ascites, intra-abdominal hypertension. So there's abdominal compartment syndrome already in this patient. The PD has been totally unsuccessful in these patients. We pump in fluid and the patient has massive, it is difficult to ventilate this child. You can't pump in fluid, or you can't create enough space for the diffusion in the PD, and SLED or HD is out of question. The patients are so hemodynamically unstable. If we try SLED, the BP drops rapidly. So we've tried CRRT, and that has shown a very good result, especially in a patient who has a little bit of stable BP on 2 inotropes. So CRRT along with the AKI, it also helps in one thing. In case of liver failure in dengue, it acts as an ammonia scavenging agent. So CRRT has been documented in the management of acute liver failure, where it scavenges the ammonia and prevents the formation of raised intracranial pressure, especially in patients with acute liver failure. So we have a paper with that. So taper IV fluids rapidly. So once your hemodynamics have been achieved, taper, allow the patient orally. Whatever he's going to take orally is not going to go into his lungs and abdomen. But if you give fluids, that's going to, go everywhere. So taper IV fluids rapidly and start with the diuresis once the patient's hemodynamics have stabilized to get rid of this excess fluid. I think hemodynamic assessment, we have an arterial line, or we can do with the other methods, but best is the arterial line. We can have a questionnaire after that, what we can do if we cannot place an arterial line. So concluding this now, and this is, I think, what we have seen or we have felt in this management of dengue fever in this case. And we all can open for discussions now if anybody feels otherwise or feels something else needs to be discussed. Yeah.
I can mute everyone.
Okay. I think, okay, I'll unmute everyone.
I think there are 2-3 questions in the chat. One question is from Anshuman. He says if the vitals are normal, but still child says abdominal pain, why do we need to worry? In confirm.
I think 1 minute, all of you can unmute yourselves.
Dr. Vikas, unmute yourself.
So there is a question from Dr. Anshuman. He said if the child is normal but still says there is abdominal pain, why do we need to worry? Yes, we need to worry, and we need to stress about the danger signs what the child can have to the parents. If the child is taking orally well, mild pain, no vomitings, and there is like he's passing urine normally, then nothing to worry. But if this child has hemoconcentration on CBC and urine output is less, oral intake is borderline. Now, what do you mean by borderline oral intake? Borderline oral intake is like, it's a bit of normal thing. Parents are not able to assess what is normal and what is abnormal. If you will ask them in the evening, has the child is taking normal? Well, yes, he's eaten what he has eaten. He has just taken 2 bites of a chapati and half a katori of dal he has taken, or some soup he has taken, but nothing else, or half a glass of water. So we need to assess it by asking them what is the actual intake what the child has taken. Second is we can ask them whether he's taken half of the normal. So this is we have to this is how we need to actually address it. So second question is commonly seeing high D-dimers too in confirmed dengue patients with negative COVID. Many kids it was more than 5,000. So what are the guidelines for that? So Dr. Mehak, would you want to take this question?
Sorry, repeat.
Dr. Deep is asking like she's seeing commonly high D-dimers too in confirmed dengue patients with negative COVID. Many kids it was more than 5,000. So what are the guidelines for that?
I think if I'm dealing with dengue, because of this confusion with COVID and dengue, we are also getting D-dimers done, especially when we have a dengue and COVID together. So, what we are
चलाती नहीं ना मैं तुम्हारा छोड़ दिया मैंने.
So what we are seeing is that if we have a high D-dimer, but if the clinically the patient has thrombocytopenia, the patient is bleeding, patient has deranged INR, I would not act on just D-dimers. I would just see the entire picture overall. We never did D-dimers in the before, and now because of COVID era, we are doing lots of D-dimers. So I would just not act on the D-dimer. I would just wait for things, because if the COVID is negative, I am not worried. I am just dealing with dengue in this patient. I would just, monitor his platelets, his hematocrit, his ferritin levels. So even D-dimer is prolonged in inflammatory syndrome as well. It can be hyperinflammatory syndrome due to dengue or because of COVID. But
yeah, with late dengue, we generally see small amount of DIC happening.
yeah,
As we told you that whenever the liver enzymes are high, PTM is also high, platelets are low. So actually, basically, some amount of DIC is there, and always D dimer will be positive. So here, this D dimer doesn't mean that we need to give them anticoagulants as we used to see in COVID. COVID positive D dimer means that we have to put them on anticoagulation. But in dengue, confirmed dengue, where the patient is in shock and you are not seeing much of thrombosis, like involvement of your lungs or involvement of your other organs, then D-dimer positivity doesn't have much value. Here, D-dimer's positivity along with thrombocytopenia, if you want to give them anticoagulation, it can lead to devastated bleeding. But in COVID patients, D-dimer positivity with normal platelets and with normal coagulation profile, then definitely D-dimers actually has to be treated with anticoagulation. So this. I want to sum it up that if you find D-dimer positive with other thing normal, you may add anticoagulation. It might help, but you have to review this anticoagulation every other day. But if you see mild amount, some amount of DIC in form of high INR or low platelets, I think these D-dimers has to be left alone. They not to be treated. So in the chat box, there's another question. If we don't have intra-arterial line setup, how we should manage or monitor blood pressure? So what I think is like it's difficult to answer because in our setup we don't have this kind of situation. Yes, if you can able to do a manual BP, then it is fine. If you can get something out of it, but if you don't have pulses, peripheral pulses are not well felt, some central pulses are there, you have to put arterial line, then only you can get adequate useful information. Otherwise, you are going to land up in trouble. Or you should shift this patient to a center where you have a intra-arterial monitoring setup, because this patient is actually a sick patient who you are not able to put, whose peripheral pulses are not palpable. Yes, but if you don't have intra-arterial line setup, you should take regular manual BP monitoring. You should do manual BP monitoring where your IBP is not correlating it well. If you're in this non-invasive blood pressure is correlating with your manual BP monitoring, then you can follow, or you should keep on doing your NIV settings or readings.
but even if I feel, considering what we have experienced, and even I talked to Dr. Gurmeet in CMC, and she was saying that even when we are putting arterial lines, we are seeing white pulse pressure. So seeing this, if the patient is having repeated fluid requirements, so you have to give high fluids, there is no harm in trying norepinephrine initially as the first agent, and then you can add epinephrine later if you think you are getting into hypotension. So that would do two things. Number one, this white pulse pressure, or you can say the low BP can be, or even if the BP is normalish, you can manage that, and the fluid requirement reduces significantly. So I think low dose norepinephrine will not cause any harm in the first 3-4 hours of resuscitation. And if you have a hypotensive shock, you can add in adrenaline. Whatever be the case, you have an arterial line or you don't. Sometimes we get patients, it's very difficult to put an arterial line. The patient are so cold and pulseless. It takes 4 hours, for us to identify a pulse and put in an arterial line. So it can happen to us as well. But I think what the learning point from us from that point was that you can start an inotrope or norepinephrine early, and that would reduce your fluid requirement and maybe stabilize the things a little bit earlier as compared to giving very high fluids in a leaky phase.
So another question is, what is preferred for colloid, albumin, or other preparations like Hemexel? I just want to say that colloid albumin is the one which is preferred, because Hemexel and gel fusion, which was initially available, they lead to a lot of coagulation abnormalities, and here the already platelets are low, so they can promote bleeding. Even one of the paper which was presented by Dr. Sujitra said that only preferred colloid is albumin rather than Hemexel. It is costlier, but yes, not costlier than the life of the patient. So I will always prefer albumin. You can use an Excel once, but if you are requiring it again and again, then always colloid. Second thing is, blood product should not be used at colloid boluses, considering that you don't have albumin and you give FFP, considering it as a albumin substitute. That is not so, because all these blood products, they come with lot of cytokines stored, because they are stored products and they have cytokines now in them. So once you give blood products as a colloid, these cytokines are actually going to decrease your blood pressure rather than helping you to improve it. So yes, you can say whether giving albumin, if you are giving RDPs or FFPs as the requirement of the patient, you can consider them that yes, these are the colloids rather than the crystalloids, but you should not use them as a substitute of albumin. That I meant to say that. So third thing is, Dr. Mehak, there's a question for you. This if there is a really quick deterioration on day 3, it was a bit early for dengue itself. Considering high ferritin levels and low white cell count, not sure if we had fibrinogen levels or triglyceride levels. Shall we consider HLH here?
I think there was a bit deterioration in this case early, but to be very honest, we are seeing lots of dengue cases with early deterioration, which never used to happen before. So patients are coming on the second, third day of illness with dengue NS1 positive reports with such deterioration. Yes, I think HLH, we considering thinking about HLH also, we do a ferritin and we start the patient on steroids in such case. But you can, I mean, there was a clear-cut history and other things in in these patients. So I'm not very sure whether we're dealing with pure HLH, but in dengue also, any infection can lead to HLH-like features. So this is one of the.
I think we are using steroids here considering HLH.
Yeah.
We are taking high ferritin as a marker of HLH, and we are using steroids rather than overusing steroids. And all these patients were coming to us in shock. So yes, element of HLH is there, but in our setup, we are not going beyond steroids as a treatment of HLH. We are not using interferons and other things, etoposide, but we are limiting ourselves to the steroids only till now. But you are right in considering that it can be HLH.
Last year, yeah, sorry. Last year also, we unfortunately we are not very good in publishing our data. But last year also we did ferritin on each of our patients admitted to the hospital with dengue. And when we had a high ferritin, we used steroids and we had seen massive resolution of shock, the thrombocytopenia recovering, the patients recovering. And this has been a marker which we have been taking in terms of HLH. We take it as an HLH and we give steroids according to the ferritin levels.
So there's another question like, are you encountering scrub typhus positive in dengue NS1 negative and dengue serology negative dengue-like illness? Yes, it is very true. We have now set a protocol for our patients so that our fellows and SRs, they should not get confused that whom to consider dengue and whom to consider scrub typhus. So what we have set protocol for our ICU is that any patient coming to emergency or ICU with higher counts, with early involvement of the organs like early involvement of liver, kidney and lung. So these patients are to be treated along with dengue as scrub typhus. Now what's the difference between scrub typhus? When we think about scrub typhus, then we have to add either azithromycin or doxycycline according to the age. So that's, we tell them that along with all other fluid management, all other ionodrop support, you add doxycycline or azithromycin if you are suspecting scrub typhus, and these are the criteria like high counts, early involvement of the organs. We definitely take them as a scrub typhus.
So yes, high counts, we take high counts as a parameter when we need to investigate scrub typhus, and even certain cases. We have one case right now who has a CNS manifestation and a liver manifestation predominantly, other than the typical dengue. So we've sent the leptospira and the scrub. So we'll see. But otherwise, yes, we are seeing other infections as well at this point of time.
So Dr. Akesh commented that the use of ibuprofen and mefenamic acid, the fall of platelets is higher and the fever settling late. Yes, I do agree, sir. So that's why I told here that for this ibuprofen or mefenamic acid has to be used in first 1 to 2 days only when the fever is very high grade. You should categorically tell them that after 3-4 days onwards, don't use any NSAID, only use paracetamol, because that can lead to rapid fall of platelets in the patient. For initially also, if you are using ibuprofen or mefenamic acid, what I do is I tell them take paracetamol. If fever doesn't subside with paracetamol, then only you should take ibuprofen or mefenamic acid.
Yeah.
So that's point well taken, sir. Another thing is, like Dr. Navdeep said, that she is facing difficulty with availability of 5% albumin. So she said they are using 20% albumin as infusion along with crystalloids. So, Dr. Mehak, what do you take on that?
So, ma'am, what we are doing is that the same problem you face, we are also facing at times. So we make 5% out of that 20% albumin. What we get at 20% albumin is sometimes we get in 5 bottles, or sometimes we get 20% albumin bag of 100 ml. So we take out 20 ml and put it in a 500 ml bag and use it as a colloid rather than a taking. And after that, the rest of the fluid, like suppose if I have a 100 ml bag, I've taken out 20 ml and put it in a 500 ml bag and given to the patient as a colloid bolus. The rest of the albumin, I use it as an infusion for the next 4 hours. So that's a very good idea. I mean, we have to work with the current situations we have and what is available to us. So we can make a fluid bolus out of that 20% by just mixing it with your normal saline bottle, and rest of it you can put it in an infusion for the next couple of hours.
So another question is, what is the right time to get ferritin levels?
I think any patient who's landing up with warning signs in your hospital should own a ferritin level. So you can monitor those ferritin levels. You can repeat the ferritin levels later if the patient is getting sick. We talk about cost issues, but I think once the dengue deteriorates, the cost issues are humongous. You cannot bring the child back. So the whole concentration should be when the patient lands up with an hospital with the warning signs. With the warning signs, we should get investigated without thinking, because if we start this patient on early steroids, we have seen improvement, and I think after COVID pandemic, we have seen that high ferritin levels that we, the in viral diseases, in HLH like picture, steroids do work. So I think as soon as the patient lands up in our hospital and owns a blood test, you should get a ferritin level.
So yes, high ferritin level can be there in a mild illness. But what we see that every sick patient has a high ferritin levels. So probably we might be overdoing the things when we are chasing ferritin levels and treating high ferritin level as steroids. But right now, this is the thing we do it. We do ferritin levels, and we say that high ferritin levels actually correlate well for HLH, and that's why we use steroids. So this is about ferritin levels. Even for patients who are obese, like we said that these are the potentially candidates who can deteriorate, you can even get them in the OPDs also. And if you find that ferritin levels are getting higher, this is the time to tell them to get admitted and treat them on IPD basis rather than having a severe situation afterwards and everybody getting so much anxiety out of that situation. So another question is adding 20% albumin mixing with NS. Yes, we are doing it. We mix 20% albumin with NS. We try to make it around 4%, like Dr. Mehak has told you, 20 ml in 100 ml of saline. So that makes somewhat around 4% albumin, and we use it as bolus. Or you can put 100 ml of 20% albumin with 500 ml of saline, and then we generally give it as a 5% bolus kind. And we then generally set it around 100 ml per hour when the patient crystalloid requirement is very high, using it as you can say that colloid infusion. But because we also get a very less amount of 5% albumin, so we sometimes use 20% in this form. Another question is that what level of ferritin dexamethasone is to be started? So what we take it, anything more than 800 or 1000, we start dexamethasone. Or nowadays what we do is sick child, dengue with warning signs, coming to with high fluid rate, we start dexa. then ferritin levels. If ferritin comes normal, patient stabilizes. After one dose, we stop it. Or if the ferritin comes high, then we continue it for 24 to 48 hours and patient settles down, we stop it.
So you don't have to continue steroids for a very long time. As soon as you think that the patient is, improving, you don't have to taper these steroids. We just, abruptly by 1 or 2 doses, we stop them if the patient improves rapidly. But if there's a deterioration, obviously you have to continue your steroids in that case.
I think we have a very lively discussion. Everybody participated so well, and we were getting a lot of requests from everyone to present dengue. So we tried what we faced difficulty this time. We tried to, we sat together, we tried to formulate new things, and whatever we changed, we found some improvement in our management. So we wanted to discuss it with everyone so that everybody can, if everybody is facing this kind of situation, they can get something out of it. So with this, I thank you everyone. I thank Mehak to take this initiative. She's the one who, pushes the limit on everyone that what we are doing. She wants she wants to share it with everyone. So I think this is the time now. So thank you everyone for patient listening. And if anybody has any other question, we have a pediatrician forum. Anybody can put any query in that, and we'll try to answer that question in that forum. Thank you, everyone.
Thank you.